Welcome all of you to this live program of the principles. Today our guest of honor is Professor Knut Beitzel from Cologne, Germany. Professor Beitzel is the head of the shoulder surgery unit at the Etos Orthopedic Hospital in Cologne, Germany, and also a professor at the Technical University of Munich. Dr. Beitzel obtained both his degrees in medicine and his master's in sports science from the University of Bonn in Germany. He completed a research fellowship at the Musculoskeletal Institute of the University of Connecticut in the United States. He's authored and co-authored a multitude of internationally published and peer-reviewed articles and book chapters, and regularly attends international conferences and meetings as an invited speaker and instructor. He received the Media Award from the German Society of Arthroscopy Society, the AGA. If noticed, Dr. Beitzel has delivered a lecture on a channel that's already reached a huge audience, and today it's my great honor to bring back Professor Knut Beitzel for this wonderful live program. Over to you, Professor.
Thank you very much. Thank you very much for this kind introduction and for having me again on your channel. And hello to all the audience. Today our topic is our approach to problems in athletes' shoulders, because athletes with shoulder problems are a very specific entity, and it's good to have a structure to approach them. And I want to give you a little bit our thoughts on this problem. So why do we have problems with athletes throwing anything or doing overhead sports? So you see this javelin throw where there is a lot of kinetic energy which runs through the shoulder joint and can make problems. We know that there are two key moments. It's the late cocking phase where the arm is in maximal external rotation, abduction, very high degrees. And then there's also the phase of the release of the projectile, where all the kinetic energy which goes into the projectile also has to be stopped and catched by the shoulder joint. And this leads to two significant moments where you have high rates of force generated inside the shoulder joint. So it's a late cocking phase, and on the opposite side, the release phase where we have high energy in the shoulder joint. And the peak angular velocity of about 7,000 degrees per second, that's a very high and very quick motion which the shoulder joint of a human is able to perform. So talking about humans and talking about the evolution, we know that also chimpanzees and apes do throw things. Here you see a small video. Usually they throw food or other things to annoy each other, but you see the motion. Basically, it's what you see when you see little kids throwing. And when we think about 3 million years of evolution to us humans, it's not only that we lost fur, we also did something different. And there's this great study from 2013 analyzing a pitching motion of a human and a throwing motion of a chimpanzee. And you see how this human pitching motion is such a corkscrewing effect where all the kinetic energy is loaded through the trunk, through the shoulder, and brings the kinetic energy. And on the other side, the chimpanzee is throwing from upwards and not generating kinetic force through the core. And this is why we are able to throw things with such a high speed compared to, e.g., chimpanzees. And it's about three critical changes which developed within the evolution. And one of the key points is that humans can twist their pelvis in comparison to the trunk. And this enables them to store a lot of kinetic energy in there. And then we also have the different shape of the muscles and the different shape of the scapula. But this enables us humans to have a lot of energy running through our shoulders. Now, when you try to look up which model and which idea to follow, there's a lot of ideas about problems and throwers within the literature. We know the vicious circle of instability of Job. We know the idea of pseudo-laxity, Burkhardt and Morgan. Kepler's idea of the six scapula, and that the scapula is the origin of the problems. And we also see anterior superior impingement of the biceps and the pulley. And there are multiple other philosophies and ideas of how an athlete's shoulder develops. However, if you look in the literature since the 1940s, when Bennett's lesion was evaluated, and then we went through all these ideas, and now we ended up in the last decade in combined treatments, surgical treatments, combined treatments, and that's not a story of success. So if you have to do surgery on an overhead thrower, you really have a problem in generating more than 70% return to sport on a high level. So we really have a problem when it goes down the road till we have to do surgery. First thing for me is when I see my patients, I think about which sport they do. We do have like the skiing, acrobatic skiing, freestyle skiing, or football, really collision athletes, rugby players. And on the other side, the javelin throwers and pitchers are very overloading athletes. We also have swimmers, which is a specific kind. And we have these in-between athletes, like handball players, as it's very popular here in Germany. They have a combination of overhead throwing, repetitive throwing, and also collision sports, where you have traumatic lesions. So for me, it's important if there is more tendency of trauma or there's more tendency of overloading within the sports. So if you look on the trauma side, I don't go into detail with this talk because this is my algorithm for instability, traumatic instability, or the discussion of subcritical bone loss, etc., where we go down this strategy. What is more important for me within this talk is the overloading, more the overloading kind of athlete. And we tried to put together in this publication an idea. I mean, it was also published before by Gelber and colleagues, also the same direction, that we think about basically 4 types of overhead athletes. So on the one hand, you have the classic throwers. They develop the posterior superior impingement. They have the pain in the rotator cuff. They have GERD, the glenointernal rotation deficit, and they have pustular lesions and all that type of rotator cuff lesions. On the other hand, you have the handball players who also do repetitive throwing, but also have a high part of collision within their sports. So in these situations, we see more problems of instability and more slap lesions combinations with the other lesions. The third group for me is swimmers, gymnastics. They have a certain amount of hyperlaxity. So in their situation, the rotator cuff has to do a high load of work. So they have an overloading of the rotator cuff, like this non-specific rotator cuff associated shoulder pain. And then that's the situation where the rotator cuff has to compensate the shoulder. And the last group is CrossFit athletes, martial arts athletes, and fitness sports. They have problems on the posterior part of the labrum. They have problems in the later stages with cartilage lesions and with the biceps tendon, osteoarthritis, and the pulley lesions. And when you have grouped them a little bit, then looking at each athlete, for us, it's this 5 keys where you can go along. You have to look at the capsule. You have to search for signs of restrictive posterior capsule or posterior muscles in terms of GERD. You have to look for the scapula, how the scapula is addressed, how the scapula is moving. You have to look for the stability of the joint and also of the core. You have to check for the rotator cuff, and of course, you have to check for the biceps and the slap lesions. Talking about the glenointernal rotation deficit, the GERD. So every thrower needs to get a certain amount of excessive external rotation. On the other hand, what you see here in this cadaver picture is when you release the projectile, there's a lot of stress on the infraspinatus. So probably if the infraspinatus is weak, this could lead to shortening of the infraspinatus, so that the joint gets decentered. You see in the middle a normal shoulder joint where the posterior capsule has the same capacity as the anterior capsule. And if you move this joint, you have a centered joint. But if you have a restrictive posterior or contracted posterior inferior glenohumeral ligament and you abduct your arm and you external rotate, then this pushes the head, and that has been shown biomechanically, this pushes the head anterior superior against the rotator cuff. So this is why the rotator cuff has to work against it, the biceps has to work against it, and that generates pain. And then you can have this posterior superior impingement idea of going down the road. You can have a cam effect, which is also leading to a little insufficiency of the anterior structures. You have the posterior superior impingement, you have the lesion within the rotator cuff when this joint is decentered, and this goes further on. So when you look at the literature, it's always discussed, but we do see the problem of a restrictive posterior capsule quite often in our athletes. So you see on the upper right a picture of a 30-year-old volleyball player, and she was playing volleyball since 15 years, and she had just pain, and it was just the GERD we had to address. Literature is showing a little bit that GERD is a risk factor for problems in athletes. And what you can do is that you can stretch the posterior muscles or stretch the posterior capsule with this kind of sleeper stretch where you're able to use it in different positions. But of course, you can also use manual techniques or other stretching techniques to get the posterior capsule stretched. And there's also data out there which showed that if you do this for a certain amount of time, it showed in the basketball players that you can have a significant reduction, and it's about 20 degrees side difference where we think it's the risk profile. Also, what I add in these situations, I add external rotation training, because I think when the posterior muscles are strengthened, they are more flexible and they can do better load sharing. This is a 20-year-old female handball playing medical student. The MRI is fine, there's no structural lesions. She played handball for 20 years, had pain in her shoulder for 2 years. Other colleagues told her she has to stop handball or suggested a supracromial decompression. We only looked for her internal rotation deficit and gave her a stretching program to address this. And this is what the email which came after 1 year, and she was back in handball playing and everything was back to normal again, even though other colleagues told her she had to stop playing handball. We also know that if the posterior capsule is restricted, this leads to more protraction of the scapula. So you can get problems with the AC joint, you get problems with addressing your scapula if the posterior capsule is not flexible enough. And the scapula is also seen as a risk factor. Again, also this is very widely discussed, very controversially discussed, but it's worthwhile to check for the scapula, because data is out there which shows that the risk of future problems with the shoulder is increased if the scapula is not running smoothly, or if there is a problem in hypertension muscles which do not lead to a proper function of the scapula. And this is because if you put your scapula in a more protracted position and rotated position, then your shoulder gets earlier into the ranges where, e.g., external rotation is limited, or where it comes into contact zones. So that's why it's important to have an adequate scapular training and get the scapula focused. And scapular orientation also has an effect on the internal impingement. If the scapula is not working properly, that leads to problem with the rotator cuff and with impingement problems. Here you see scapular assisting test. Here's a patient with a scapular dyskinesis with pain. And just by correcting the scapular position, the pain gets away. So this is a candidate for training of the scapular muscles. And we have very nice training programs published by Allenbecker and Kuhls, who did a lot of work with that, which give you a very good algorithm how you can address the scapula and how you can train the scapula. And what's also important for me is not only the weak posterior muscle, it's the shortened pectoralis, it's the overstrengthened anterior muscles, which also protect the scapula. So it's important to look for that and stretch them. Here you see a patient with problems in the prone position. And you see that the right shoulder is, due to soft tissue restrictions, a little bit more anterior. And that's why this is shortened, and you can address that with physiotherapy. The next point is the rotator cuff. So never work the cuff until failure. We know from good data that with repetitive motions, the rotator cuff, especially the posterior rotator cuff, gets tired, and this leads to a wrong positioning of the scapula and decentration of the humeral head. So it's important to produce a good resilience of the posterior cuff, as you see in these fantastic videos from the Oslo Sports Trauma Center. And external rotation strength correlates with a risk for injury. We know it from our return to sports criteria. We know that it's very important to have a proper posterior cuff working properly, and this allows you for a resilient repetitive motion of the shoulder. And the next point is the kinetic chain, the trunk. I told you it's about stability of the joint, but it's also about stability of the core. And if the core rotation is not optimal, then you have peak loads on the shoulder joint or on other joints, which can generate problems. This is test for the core. I do a single leg squat, as you see in the upper picture, with a positive Trendelenborg. This is a patient, a tennis player, was a tennis player, and there we can center our training on core stability and get his hips working properly, that he can share his load. We looked at a group of athletes. So we had the German national junior team for javelin throwing, and we had sport-specific boarding schools, volleyball players. And we thought about what happens to young athletes who don't have any problems yet. So we included these guys, and this is the MRIs from the javelin throwers. So 18-year-old, 17-year-old athletes, no history of shoulder trauma. And we looked at them with the MRI. And what we found was much higher degree of posterior cysts in the infraspinatus area. We found in dominant arm about 70% of the javelin throwers, and usually you don't have this high amount in these young patients. And we didn't find that in volleyball players. So there happened something even in these young athletes. So we also put them to YCON testing to see the scapular motion. We put them to isokinetics, and we put them to all the angulation measurements. And what we found with this group was that they all had a little bit slightly changes in the direction. They had a little bit girth, they had a little bit of scapular anterior tilt and all these things, but it was not pathologic. But you see all of these changes occur even in these young athletes. So when we go for treatment, prevention is very important. And Jeff Kuhn had a nice word with saying, we try to address the core stability, the rotation deficits, the external strength, and the scapula. And these athletes, they are on the edge of a cliff. They need a certain amount of specific changes to get perfect in their sports. So we have to bring them back. We don't have to make them normal. E.g., if you have a thrower and he has a slight pasta lesion, and you would repair the rotator cuff and medialize the pasta lesion, then he cannot throw anymore because he needed the space. So we have to be aware of that and be very careful. So for us, one important part was preventive exercise. So with the group of national athletes, we put together a preventive exercise protocol, which we published also a couple of years ago. And there we also included these specific things for rotation, for core stability, and the external rotation strength. And I told you about the Oslo Sports Trauma website, which is really fantastic. If you need some ideas of how to get your patients, show your patients how to do some of these training things, improve the external rotation and improve the scapula, you find very nice video on this homepage. This is a 36-year-old picture. Here, the pasta lesion had some reaction, had a massive GERD, had scapular dyskinesis. You see the Trendelenburg. We put him into conservative training. We addressed all these points, and we brought him back to his sports without surgery. And the keys, as I told you, with Ann Kuhl's algorithm and also with our publications, is that you address the capsule, that you address the high tension muscles, detonize the anterior muscles, get training for the scapula, get the external rotation going, and then go into the strength in core training. And there's another athlete. It was a 25-year-old athlete, a volleyball player. I initially took him into conservative treatment, but then he came up with the story that he had a skiing accident 6 months ago. So now this volleyball player switches into a traumatic injury. And in his situation, this was a problem of the anterior inferior labrum. So we fixed the labrum, did a tenodesis of the biceps, and brought him back into full motion again. And this is another example of a patient, a 24-year-old female police officer, very young, high sports, three years pain, all injections, everything, done everything. But at the end of the day, you see it in the pictures, it was a pasta lesion. So we repaired and fixed. Here you see the intra-articular picture. This is biceps tendon coming up here, subscapularis. So we addressed the biceps with subpectoral tenodesis, and we fixed the pasta lesion with all suture anchors and then a double wire procedure, and get her back into sports. And together with the group in Munich, we published some of the data also of these combined patients. I mean, it's always patients who have multiple factors and you need a combined treatment. So we showed good results with that. And this is another guy, a 23-year-old male patient. And this is one of these athletes, type 4 athletes, martial arts athletes, who do these things. And in his situation, it was a posterior instability. So we addressed this posterior instability. Here you see the video of the labrum, and we fixed it posteriorly. And with this, we brought him back into his sports. And this is a little bit of a look into the future. So what we can do in the future. So we work very nicely with EMG controlled biofeedback. So our physiotherapists can put EMG on the shoulder muscles and can show the patients very nicely when they have a high tensioned trapezius muscle or problems with their periscapular muscles, so they can address that and the patient can learn that. And on the other side, where we also work with blood flow restriction training, we believe that we also have an effect on the shoulder muscles, which has been shown also in previous studies. And this effect we can use to strengthen the calf with not so many high weight loads, which is perfect, especially in this type of rotator cuff associated patients. But this, of course, is experimental. I mean, it's just ideas where we think we can go in the future. So taking this together is like, it needs a multiple factor approach. It needs a structured approach, although we have low evidence on whatever we do. We believe that we should look for the 5 keys for the capsule, the scapula, the stability, local and core, the biceps tendon with slap and pulley lesions, and the rotator cuff with its integrity. We know that we mostly have a conservative treatment and we need a combined treatment to address all these factors. We believe that's very important to not let them fall off the edge. We need prevention. We need to make all these athletes, and especially the young athletes, clear that they can do preventive measurements. And so we try to keep them on the edge and don't want to have them fall off the edge. Thank you very much.
Thank you, Dr. Beitzel. You can stop sharing, Dr. Beitzel. Thank you, Dr. Beitzel, for this amazing presentation. Let's have a short Q&A. Now, Dr. Beitzel, we commonly say about slap, right? Slap and throwing athletes. For example, even you mentioned about glenohumeral internal rotation deficit. Now, these also could be associated with SLAP, isn't it? So do you address these surgically? Because very often we get on a pre-op MRI that there is a SLAP associated. So how do you treat the associated SLAP?
So for me, thinking about 20 years ago, the SLAP gets less and less important. So for me, the economic motion of the shoulder gets more and more important. So if the shoulder is in a good range of motion and rotates harmonically, there is less load on the SLAP. For me, SLAP lesions really are of interest if they are rather traumatic in terms of when I have to treat them. So I'm very restrictive in going for biceps tenodesis. I do it with a subpectoral tenodesis. I very rarely treat SLAP lesions by fixing them. It's only for very young athletes with a SLAP 5, like an instability which goes up into the biceps, or the posterior instabilities, labrum lesions going up to the biceps. So in these situations, I fix it up, but I'm very, very getting more or less favorable for me to do SLAP repairs. The biceps tenodesis for me is the way to go, because we also know that about in 40% of these patients, they have also a problem within the pulley and within the rotator cuff. So with going subpectoral, I'm fine with that.
Thank you, Dr. Beitzel. Now, Dr. Beitzel, you also mentioned about scapular dyskinesia, right? So this is a very poorly understood problem, isn't it? For example, even Dr. Ben Kibler has done a lot of research, but do you see them in throwing athletes commonly? And how do you treat them? Is it with rehab, isn't it?
Exactly. So absolutely. So we tried with our Wycon system to objectify the scapular motion. And I can tell you that's a hell lot of work, and you never get to a real point in saying what's normal and what's not normal. And also with Ben Kibler's ideas, and I think what I've heard with him and discussed with him within the recent time is he's getting more and more to a pragmatic approach, and not so much to like type 1, type 2, type 3. It's like, is the scapula moving homogenic or not? And especially what's important for me is the scapular assist tests. So if I put the patient into a joke testing position and they are in this type of swimmer's weak rotator cuff, overloaded rotator cuff, and then when they do this, they drop down with their scapula kind of. And when you assist them in fixing the scapula and then get the force, and then they get rid of the pain, this is a sign for me that the scapular muscles need more coordination. And this is very well for us. It also gets into a little bit into the posterior instability, the shoulder pacemaker thing with the wall slide test. And this is where we work with the EMG biofeedback, and the guys who perhaps I can get Philip Pirot's address to you. He's doing nice talks about that. And he can show with his EMG that the trapezius is overreacting and that the rhomboidials are less objective. And in this situation, I don't want to have a classification of the scapula. I just want to show the patients that they see how they overreact with their trapezius. And there you can go in and then you can train, because they, with the biofeedback, they can see what happens. And that's not all the patients really get this idea. And then you can do the core of the scapula. If this one is fixed, then you can build up the rotator cuff centration.
Thank you, Dr. Beitzel. Just one last question before we end up the session. Now, Dr. Beitzel, you also mentioned about posterosuperior impingement. That is another less commonly understood problem, right? The greater tuberosity hits on the undersurface of the cuff. And how do you treat these? Is it surgically or non-surgically?
Also, this is a topic which a couple of years ago, when we started working into this direction, was a very famous topic. And I think it is a problem that the pitching athletes are a little bit special in all this, because they have a twisting motion in there. But that's not what we see here in Europe. We see more the javelin, the handball throws. And in understanding the importance of the posterior tightness, of the weakness of the posterior cuff, this gets more and more important for me. So that if I manage to get the shoulder into a good economic range of motion, then they can deal with that, and then they don't have the problems there anymore. And what is really an important factor, and I think which is the reason why, if you look in the literature, debridement of the cuff in these situations has better results than repairing the cuff. And this is perhaps, if you do repair the cuff and you go too medial, then they cannot get their external rotation. So if you go down the road and you have to repair the cuff, you have to give them a little bit more space and be careful not to over tighten them and to medialize them, because then they cannot get into this position. And that is the natural area. So the posterior superior impingement, by checking our keys, is just more one part of the theory, but that's not the one pathology I'm addressing. It's more the end line of getting down the road with all the other stuff.
Thank you, Dr. Beitzel. Dr. Beitzel, that's all the questions that we have for this session. Thank you for yet another amazing presentation, and really look forward for one in the future.
Thank you very much for having me again.